a great day today with the great lectures and some nice case discussions. And we are promised today with the first-time tumor board in the after prayer and lunch, and that's really unique. We'll have a great panel from the AUA faculty, Saudi expertise, and medical oncologist, pathologist, and radiologist, and radiation oncologist. That will be really something new. We're looking forward to it. Without delay, please show us some new things.
Well, good morning, everybody. So for those of you I haven't met, I'm Seth Lerner, and I spend most of my time working in the area of lower and upper urinary tract cancer. So I think I've got about just short of 2 hours with you this morning, maybe a little bit less. So I think the order of things is just going over the highlights from this year's AUA meeting, and then I'm going to give you kind of a broad overview of kind of a risk stratified approach to treating non-muscle invasive bladder cancer, and then talk about what I find one of the more challenging aspects of taking care of patients with bladder cancer, and those are the patients who recur after BCG. And then I put together some cases that we can discuss. I'm happy to discuss some cases of yours as well. So this talk was prepared by Angie Smith. Angie's a brilliant young urologic oncologist at University of North Carolina, and I've added a couple of things to her talk along the way. So we'll go ahead and get started on this. So there were a variety of sessions in addition to the peer-reviewed posters and podium sessions, and I'm going to go through some of that with you. You can just see the volume of material that was covered. So it's interesting to think about how often and in whom do you surveil the upper urinary tract following a diagnosis of bladder cancer. And we probably don't need to do much surveillance in patients with infrequent recurrence or of low-grade disease, but high-grade disease. Harry Herr published a paper many years ago that showed that, particularly in patients with carcinoma in situ, that there was about as much as a 25% risk of developing a second primary tumor of the upper urinary tract within 10 years. And so this paper was sort of addressing the need for that, and so I would recommend a risk stratified approach to surveillance and primarily focus that on patients with high risk or high grade disease. And then following radical cystectomy, there have been a number of papers over the years that have addressed the sort of frequency of surveillance. What I can tell you that when you look at the breast cancer literature, they've actually done randomized clinical trials of thousands of patients asking a question about, does periodic CT scan contribute to overall survival? The overwhelming answer to that is no. And so I think that within the first 2 years after a cystectomy, cross-sectional imaging is important, and probably continue that in higher risk patients. And then long-term, we'll monitor the upper urinary tract with simple renal ultrasound because these patients can get late deterioration of the upper urinary tract that's going to be silent, or asymptomatic. So this is a nice review of CX bladder. This is one of the many urine biomarker tests out on the market, and in this particular study they had very high performance characteristics in terms of accuracy and negative predictive value. So for the value of a urine biomarker in surveillance, we want to make sure that we're not going to miss any high-grade disease. So we want a high negative predictive value and a high sensitivity for high-grade disease. And then there was another paper about CK20 and IGF-2, insulin growth factor 2. And I just heard some interesting data on CK2 that CK20 that depending upon the context, it can actually be associated with more aggressive disease, although the pathologists use it quite nicely with immunohistochemistry to identify urothelial cancers. There's a very large emerging body of work looking at steroid hormone receptors in bladder cancer. We've been working on this for about 15 years in terms of estrogen receptor, in particular ER beta. But there were some nice papers looking at the androgen receptor, obviously very important in prostate cancer. But these three papers address some of the issues with respect to AR and bladder cancer. So I think there's more to come with the story. We're certainly not in a position to think about targeted therapies like we do in, or secondary hormone therapy like we do in prostate cancer, but this potentially could open up new avenues for clinical trials in the future. I put this in because this is something that I've seen now several years, various abstracts, various ways of doing this. The concept is, particularly in low-grade disease, instead of doing a resection through the tumor and dispersing cells all over the bladder and perhaps increasing the risk of implantation, making it very difficult for the pathologist to interpret, the idea of doing a non-block resection. So I don't know if there's any golfers in the audience, but it's sort of like we're taught as to how to get a golf ball out of the sand. You don't really hit the golf ball, you hit the sand underneath it. And so you can take a Collins knife electrode, which is what I use, and just incise the mucosa around the tumor and use it to sort of dissect underneath it. Not so good in invasive high-grade disease, but the idea is that, and this is especially important as I'll show you later on, in the setting of high-grade disease, to get, intact lamina propria and muscularis propria with that tumor. So if you present all that to the pathologist on block, they're going to have a much better idea of the spatial resolution of the tumor and the underlying stroma. This was a long-awaited result of a randomized phase 3 trial looking now at, let me ask you a question real quick. Do you have any of these newer endoscopic imaging, say blue light, do you have blue light fluorescent cystoscopy, anybody? Okay, how about if you use Olympus today, you're going to get this narrowband imaging. So we've been working with Hexvix or Cysview for quite some time. This was a randomized trial asking a question about doing it actually in the office in a diagnostic setting, or sorry, a surveillance setting, and then taking those patients who were positive into the operating room, subsequently using blue light again. So they showed two things, that the accuracy with flexible cystoscopy really reflected what they've shown previously with rigid cystoscopy, and that the second use of the imaging agent, the intravesical imaging agent, was safe and effective. Several studies looking at intravesical treatment. I'm going to go over the SUA 337 in the next talk, I believe, so I'm not going to talk about that. And then what I mentioned yesterday about the clinical trial using mitogel, the thermosensitive gel with mitomycin. Same company's done a nice study primarily in Europe and shown at the 80 milligram dose it was very effective in actually ablating low-grade tumors that were left in place. So more to come on that. I do know that they're planning trials in the States as well. A lot of work with alternative or other types of immunotherapies for non-muscle invasive disease. These were two studies looking at cancer vaccines. Panvac has been around for a long time, and this was a randomized clinical trial. And then there is a whole lot of largely preclinical data suggesting that in a non-immunized patient population, that priming the system with intradermal BCG, sort of vaccinating the patient, sort of in a time frame of about 21 days prior to administration of BCG, may actually help boost the immune response. So you know that with the initial 6 installations of BCG, it takes about the 4th installation to start seeing peak induction of cytokines, primarily Th1, interferon gamma, and that's sustained through 5 and 6. So the idea is that by priming, you can actually accelerate that sort of peak induction of cytokines, and that may improve the recurrence-free survival. So we're testing that in a big clinical trial, almost 1,000 patient trial in the Southwest Oncology Group. So here was some additional preclinical evidence to support that. I'm going to talk a lot about BCG refractory disease or unresponsive. That's the third talk of this series. This is some really nice work. Gary Steinberg from University of Chicago has been sort of the driver behind this with the company that has this particular replication competent adenovirus, which drives GM-CSF, I believe, and showed some very nice results in a very difficult to treat patient population. I put this in because I've become quite good friends with Charles Rosser, who's the clinical PI on this. This is Altor Biosciences. This is a mutated version of IL-15. You can see the impact that it has on a variety of different cytokines. They're looking at it in a BCG-naive patient population, and then in a patient population that's recurred after BCG. And actually, Charles' poster won best poster that particular session. So this is a drug that looks like it has some legs and moving along quite quickly. Angie, I think, included this because this is an area of research that she's quite interested in, and just showing that, and there have been other work showing the level of distress, particularly in patients with non-muscle invasive bladder cancers. So, we tend to think that for us it's not a life-threatening illness. In many cases, it's sort of like in some respects, it's a nuisance, but it can have profound implications in health-related quality of life measures. And then there's a whole body of work, particularly in the medical oncology literature, talking about financial toxicity, particularly of systemic chemotherapy targeted agents. A 1-year course of atezolizumab, last I checked, this is one of the new IO agents, is $133,000. And so when we're sitting there discussing all of these things with patients, and I realize that it may not be as applicable in a single-payer system where health insurance is part of one of your benefits of being a citizen, in a country like ours where this can have profound impacts on the financial burden for the patients, and this was a nice study looking at that. A lot of work being done on variant histology. I don't think I get into this in any of my talks this morning, but it's very important to have a pathologist who's attuned to these various variants. So pretty good about squamous and adeno, the sort of more typical mixed histologies, but they need to be attuned to things like micropapillary. We see a reasonable number of small cell neuroendocrine tumors. We teach those we treat those a little bit different, and the outcomes can be different too, depending upon the particular presentation and treatment regimen. So we need to have our geopathologists quite well aware of this. I was part of a nice session looking at the importance of node metastasis and the surgical aspects of treating patients with both kidney and bladder cancer. This is an area that I've spent quite a bit of time in. We have a big clinical trial randomizing patients to extended versus standard node dissection and radical cystectomy that's completed accrual, but won't report out now for another couple of years. And so these were just some nice papers looking at that aspect of invasive bladder cancer. Another area that I've invested 7 years of my life, since 2010, is molecular subtyping of bladder cancer in the context of the Cancer Genome Atlas project. And there's relatively new data, not so new to oncology, but new in bladder cancer, where alterations in DNA damage repair genes are associated with a higher response to cisplatin-based chemotherapy. And there's going to be a clinical trial that's activated in the cooperative groups in the States testing this hypothesis that if you have a DNA damage repair alteration and you get systemic chemotherapy and you have a complete response, that it may be safe to watch those patients without additional therapy, either a cystectomy or a radiation therapy. And these alterations occur in maybe about 1/5 of patients to 1/4 of patients. So sort of an interesting approach to that. And then the idea that particularly the basal squamous phenotype, or molecular subtype, may identify patients that are more primed to respond to cisplatin-based chemotherapy. And this is just a figure. This is Roland Seiler's work that they did with Peter Black up in Vancouver, and working with a company called Genome DX, where if you look here on the left, these are the different 4 subtypes that we described in the first TCGA paper in 2014. And if I can get the pointer. Well, what you see is in the red line, which is the basal squamous now treated with chemotherapy, that they move into a much more favorable subgroup, very similar to luminal papillary, which we think may not necessarily need or benefit from systemic chemotherapy. There was a long-awaited results of a trial. Indy alluded to this yesterday. I actually showed you some data Dippin Parrick is the PI. Dippin is the chief of urology at the University of Miami and has an R01 grant to study this. So this is a randomized trial, multi-center, 15 or 16 sites comparing open and robotic. This is the so-called RAZOR trial. And basically what they showed was that there really was no difference in the primary outcome measure of progression-free survival. Although when you get into the weeds a little bit, it's not necessarily the way I would design a trial. They included some favorable risk patients in there. But this is really the kind of research that we need to be doing as a community. It's a surgical trial. This is things that we do every day, and trying to develop higher quality evidence to support particularly the outcome measures. And so there's never been a study to date that shows that there's similar survival probabilities with open versus robotic. This study actually doesn't fully answer that question, but it gives us really the first high quality evidence to suggest that there may not be that you may not be putting your patients at risk by choosing one over the other. A question just in a sidebar conversation yesterday in terms of the particularly, well, any of the guidelines, but the AUA guidelines in particular, that having content experts involved in it. And I can assure you, at least from my experience, so I've been on the muscle invasive panel. It's been a wonderful collaboration with the AUA, ASTRO, and ASCO, the Radiation and Medical Oncology Societies based in the US. And it's a very robust discussion, evidence-based, although you'll see that the quality of the evidence doesn't necessarily rise up to the standards that we would like, but so Jeff Holzberlein gave a very quick rundown of this, and I've just highlighted a couple of things. So I suspect that you're aware that there's level 1 evidence from 2 large randomized clinical trials supporting the use of only cisplatin-based neoadjuvant chemotherapy in patients who have adequate EGFR prior to radical cystectomy. Carboplatin-based regimens are not effective. So if you have a patient who cannot get cisplatin for either pre-existing, particularly peripheral neural toxicity or hearing loss or EGFR, then there's no role for any other regimen. They should go straight to cystectomy. And the other thing that is really the first key principle in the ASCO guidelines, which they adopted largely the EAU, is that these patients with muscle-invasive bladder cancer, the standard of care is a multidisciplinary consultation for really every single patient. We dealt with some of the issues with radical cystectomy, just sort of defining what constitutes an adequate cystectomy. Women really do not need to have, unless there's obvious involvement, removal of the uterus, cervix, and ovaries, particularly when preserving those organs, not necessarily for fertility purposes, but rather for pelvic support and various considerations in pre- and postmenopausal women, and also to just think very carefully about the potential negative impact on sexual function. Because of the presence of the ASTRO, Anthony Zeitman and Jeff Mikulski were on the panel, both world-class radiation oncologists. You'll see a very robust discussion and inclusion of particularly trimodal therapy. So trimodal therapy is a maximal TURBT followed by chemoradiation therapy, and the urologist, medical oncologist, and radiation oncologist are all completely engaged in treating the patients. And this is the last scary algorithm, and quite a lot of effort was put into this. And so this is a nice tool that you could have in your clinic to kind of guide you through at least the guidelines sort of view of how to organize this. So this, remember that the AUA guidelines are available on an app on all the Android and iOS systems, and it's a pretty handy tool. So that's the end of that talk. And I'm happy to take any questions at any point in time. Yeah.
Thank you very much for this nice review. Have you ever had any experience with hyperthermic intravesical chemotherapy, and what's your thought about that?
So the question was about hyperthermic and you're talking about intravesical, like Synergo, for instance. I don't have any personal experience, but the data are rather compelling. I think I've got a slide on this just to make sure I remember to mention it. And not the current talk, but the next talk when I get into BCG unresponsive disease. So we should talk about that. The idea is with heat, either heat or electromotive therapy, you can drive a drug like mitomycin C into the wall of the bladder, through the epithelium, into the tumor, the dysplastic tissue, and the data are really quite compelling, particularly in terms of being able to achieve durable CRs in very difficult to treat patients. Do you have that here? Do you have some over here? Yeah, yeah.
You mentioned about the BCG vaccination before BCG treatment. Are we talking about BCG, the regular BCG for tuberculosis or something different?
A
Because
vaccine.
I think it's mandatory here. Every child should be vaccinated. So will this suffice, or you have to do it again? Or?
Yeah, so the question, so the first thing is, yes, it's the standard intradermal vaccination that one would get, as a child, right? So that's never been the case in North America. So, but having said that, that's been studied in Europe as well. And so, the question comes in a pre-immunized patient population that's been immunized for TB. Is there going to be an incremental benefit? But when you look at the data and ask the question about a previously immunized, non-immunized, I'm not aware that the immunized patients respond any better to BCG. Now, I'm not going to get into this, but there's a lot of very interesting data about strain differences of BCG. So when you look at the phylogenetic tree of BCG, it's a real mess. I mean, starting back with Armand Frappier in the Pasteur Institute, there have been all sorts of genetic modifications, and some of those genetic modifications over time have probably weakened some of the immunogenicity of BCG, such that there's some concern that TICE, for instance, which is the only BCG available in North America and other parts of the world, may not be as effective as, for instance, Connaught, but Connaught's no longer available. And so the trial that I was mentioning is going to compare Tokyo, or the Japanese strain, with and without vaccination versus TICE. So hopefully we'll be able to answer all those questions. So in our trial, everybody's going to get a PPD. If you're PPD positive, then you can't go on the study. And we estimate that in North America, that'll be about 3% of patients.
Dr. Lerner, just a quick question. In the RAZOR trial, they said there are more positive margins with the robotic approach on the soft tissue. What do they mean by the soft tissue?
So the question is about soft tissue positive margins, robotic versus open. And I think there's a real risk there. However, there's a profound impact of true positive soft tissue margins. So this would be tumor extending through the bladder into the perivesical fat. Those positive margins do not include CIS at the apical urethra or CIS in the ureter. That's a different story. But if you look at true positive surgical margins, which occur in about 3 to 4% of cystectomies, it has a very poor prognosis. That doesn't come as a big surprise because these are big, bad, aggressive tumors in order to get that far advanced. And there is some concern that minimally invasive approaches are associated with higher positive margins. But I think the challenge there is that may simply represent a tumor that's penetrated full thickness through the bladder, and no matter what you do, you're going to have a positive margin.
Yeah. One last question.
Excuse me, regarding the neoadjuvant chemotherapy, I don't feel comfortable to give every patient chemotherapy before cystectomy because two things. One thing we know from California data and from Egyptian data that 80% of T2 disease, they will be cured by cystectomy alone. The second thing, if you look to the Harvard data of the chemoradiation, 30% of their patients, they are chemo resistant, so they excluded from the data. So what's your feeling about this?
Okay, the pushback to that is there's two lines of evidence that would suggest otherwise, okay? So if you take clinical T2s, half of those patients are upstaged pathologically. So we really do not have very good tools yet to identify patients that are going to be true PT2s, node negative, versus those who appear to be, who are clinical T2s that are going to have more advanced disease. So in that setting, and then if you look at the SUA trial, the randomized trial of 3 courses of MVAC plus cystectomy versus cystectomy alone, the benefit was accrued to both groups of patients, patients with organ confined and non-organ confined. And so there's really no compelling evidence to suggest that there's a group of patients that we can identify with the tools that we have today who otherwise are cisplatin eligible that we should not be offering cisplatin-based neoadjuvant chemotherapy to. So that's the first thing. And then with respect to chemoradiation therapy, I'm sorry, what was your question again? Sorry. Right. Yeah, so here, I want you to remember this number. So if you take 100 patients with muscle-invasive bladder cancer, about 25% of them, if you gave everybody, let's say you could give well, first of all, you can't give everybody chemotherapy, but about a quarter of those patients ultimately may derive a benefit from cisplatin-based neoadjuvant chemotherapy. How did I get to that number? Like you say, half of them are not eligible, so to speak, eligible for cisplatin, either because of pre-existing comorbidities or inadequate EGFR. So those patients, I agree, go to cystectomy, or if they're not cystectomy candidates, do chemoradiation therapy. Of those 50% that get cisplatin-based neoadjuvant chemotherapy, the most optimistic data would suggest that half of those patients will derive a benefit, and the benefit is defined by PT0 rate or only residual PTA, PTIS, or PT1. PT1 is probably intermediate. So if you can take a patient, and the other thing that I want to be very clear about is that when you compare the two arms, cystectomy versus neoadjuvant plus cystectomy, there is an undeniable delta between the PT0 rate with cystectomy alone versus chemotherapy plus cystectomy. So the challenge for us is not to withhold potentially life-saving or benefiting chemotherapy right now, but the challenge is to design the clinical trials so that we can identify those patients who are most likely to benefit. That's precision medicine, and then come up with other ways to help the patients that can't get it. Does that help? Okay. One last question.
For patients with the PT1, PT2A mother cancer, how long do you follow them up by cystoscopy and maybe for PT1 by upper activity?
Yeah, okay. So are we talking just about high-grade disease?
No, across the board.
Okay, so for low-grade disease, I don't think you really need to do any upper tract imaging past the original diagnostic one, unless, of course, you then develop a high-grade tumor, or you're seeing these multifocal recurrent tumors in the bladder, low-grade, because it could be a sign that something's going on in the upper urinary tract. For high-grade disease, and CIS, TA, T1, those patients are at higher risk long-term for developing a second primary tumor of the upper urinary tract. So 1 year, 2 years, right? And then probably every other year, maybe certainly out to 5 years. And personally, I'm not really sure that the evidence is compelling enough to continue it on indefinitely. Because remember, we're exposing those patients to radiation, right? And that's not free. That doesn't come free long term. So the other way you can do this is to incorporate a voided urine biomarker into your follow-up long term. So what we have, and I'm not allied with any of these companies. I don't do biomarker, well, actually that's not true. I do some consulting with a company called Nucleics, which has a new biomarker using methylation-based approach. But So I do FISH in these patients. I do cytology. I do a wash cytology for obvious reasons. And I do FISH because it's a voided urine test, which gives me a readout on both upper and lower urinary tract. So in the high-grade patients, when I really have stopped doing cross-sectional imaging, probably after about 5 years, I still keep them coming back. I don't scope them anymore after 5 years, but I'll do this voided urine marker. And I think that maybe is a bit of a compromise. But anyway, why don't we move on? We've still got lots to talk about. I'm going to just get a little sip of water. So this is something that I've been teaching for quite a long time, and I just want to acknowledge a couple of people in just a minute. If you weren't here yesterday, this is where I come from, the Texas Medical Center in Houston, and this is our new campus. This is where we're currently working, and this is a hospital that's not quite built yet, but we're very excited about the expansion of the Texas Medical Center. Now, I am going to be talking about some of the potential conflicts of interest. So let me just walk through this really quickly. I've got an investigator-initiated grant with ENDO. FKD and JBL are supporting 2 clinical trials in SWOG, and then we've started a clinical trial using atezolizumab for BCG-unresponsive disease, and Viventia has an intravesical therapy in the identical disease state, and I do some ad boards and consulting. And then for this talk, Isla Skinner and Badri Canetti and I ran a course for about 9 years at the AUA, and this is sort of the updated version of that, and I've borrowed from some of their slides as part of that course. Already talked about this. There we go. Okay. So from the outset, in order for us to be able to make good decisions for our patients about treatment, then we have to have in our heads a pretty well thought out and understood risk stratification scheme. And so this is the risk stratification for the new muscle invasive guidelines that were published by the AUA. I think it actually got published in 2015. And so it's a little bit of a twist on the EAU risk stratification. So in the most simplified way, any patient with high-grade disease, so papillary Ta2 or carcinoma in situ, is by definition high risk with one exception. What the AUA did was took the TA high-grade solitary small tumors and put them in an intermediate risk category. So that's very different than what the EAU classification scheme is. That's one difference. And then a patient with a first occurrence of a small TA low-grade tumor, which is probably the most common presentation, is low risk. We want to do as little intervention on those patients because they really don't have really much to be concerned about. And remember that risk stratification is driven around, largely driven around progression risk. So, progression from a low grade to a high grade, or a high grade non-muscle invasive to a muscle invasive cancer. And then everything that's not one of those two extremes is in the middle. So these would be the low grade, multifocal low grade, frequently recurrent tumors that have about a 15% risk of progression to a more aggressive cancer. I'm going to get into that. Yeah, I'm going to talk about. No. The risk stratification is completely independent of the issues related to BCG. No. Is that what you're asking? Yeah. Yep. Nope. So this is the EAU risk stratification, and this is actually, I find it really easy because any high grade's high risk, solitary TA low grades is low risk, everything else in the middle is intermediate risk. And then they went on to further clarify this very high risk category, and those patients probably ought to be treated with initial cystectomy. Oops. Okay, so I've got a couple of cases, and this will be relevant to the cases that we come back to at that portion of the this morning. So 60-year-old lady gross painless hematuria. Unfortunately, in the States, the primary care doctors don't work up gross hematuria in women. It's really awful. The data really are bad, and so as ends up happening sometimes is you'll see these patients after they're diagnosed with a muscle-invasive bladder cancer, typically treated with a bunch of antibiotics, and then finally someone picks up and does cross-sectional imaging. She has an obvious tumor. Endoscopically, it looks low-grade. Histologically, it's low-grade. And so she has low-risk disease. And the standard of care for those patients is a single dose of perioperative intravesical chemotherapy, usually administered within about 24 hours of the procedure, okay? And sometimes we'll do this in the operating room where it's convenient, as long as I'm not concerned about any deep resection. Remember I talked yesterday about mitomycin being a desiccant, and you don't want it to get into the soft tissues because it'll cause a lot of necrosis. But two meta-analyses showed a very highly statistically significant reduction in the probability of recurrence. And it's not just with mitomycin, it's been looked at with epi and a variety of other drugs. I've got a slide on that. And these are some of the dose ranges that you'll find in the literature. And then I'll show you what we're very excited about in the SWOG, long-awaited results of 0337, which looked at perioperative gemcitabine, and that was a positive trial. Keep the drug in. We usually keep it in for about an hour. Here's the key. We always have to say this: never, ever, ever use BCG in this setting. And I suspect that's obvious, but you've got a very raw surface area, and you can, much higher risk for systemic dissemination of BCG. And don't use it in the setting of perforation. So this is the Kaplan-Meier plots from 0337. So this was a randomized trial of perioperative gemcitabine versus saline control, and a highly statistically significant reduction in time to recurrence in both the intent to treat and particularly, which was the target population, low-grade patients who received treatment. And this manuscript is currently under review by JAMA, and at least in our shop, we're going to move away from mitomycin to gemcitabine for two simple reasons. Mitomycin is very expensive to get because it has to be compounded, and there are these toxicity issues that you simply don't see with gemcitabine with intravesical therapy. There are some controversies and some variations in recommendations by the guidelines, and the real benefit probably is in really just patients with low-grade disease, so we typically do not use it in patients who are going to go on and get an induction course of BCG. So if you have a high-grade tumor, and of course you don't always know that at the time of the TURBT, those patients probably do not need to get a perioperative dose of chemotherapy. And then there have been two large randomized trials, 800 patients each, with a drug called apaziquone, which is really a very nice sort of precursor drug to mitomycin with much less toxicity. Unfortunately, both of those were negative and turned down by the FDA in last November. So this is a patient who got a single dose of perioperative mitomycin C. This is a patient that I saw in consultation, and you see at the top of the bladder these areas of dystrophic calcification. You see some disruption. Actually, it's probably a diverticulum, pseudodiverticulum, and the challenge is, if you see this, is to not open the patient and try to fix it. Stay very far away from that. You could usually nurse these patients through this toxicity with appropriate anticholinergics and symptom control and time. And then this is a rare toxicity of ulceration of the buccal mucosa with gemcitabine. Here's another case. 75-year-old male, has a history of a low-grade, low-risk tumor. Got mito, now has recurrent multifocal TA low-grade disease, so by definition, intermediate risk, okay? And this is the definition. So absence of high-grade, multifocal, recurrent tumors. And in that setting, when you compare the data between BCG and mitomycin, BCG appears to be the winner only when maintenance is used. And the challenge there is that the proper, well, my opinion is that the proper use of mitomycin has not really been what's the current standard of care in those trials, which is 40 milligrams and 20 cc's, so double the dose, double the concentration, alkalinize the urine by giving them bicarb the night before the morning of, and making sure they have no urine left in the bladder after catheterization. This is elegant work done by Jesse Au, published in 2001, and the optimized regimen of mitomycin C is associated with about a 50% recurrence-free survival at 5 years. So that in that context, a lot of people do use BCG in this setting. My preference is to use intravesical chemotherapy and hold the BCG back for when patients recur, or only those patients with high-risk disease. It looks like I beat myself to the punch. This is the data from that trial. And do you use mitomycin C here? You have access to it, I assume? Yeah. So memorize this. I'm just going to leave it up here for a minute. Take pictures if you like, if you're not familiar with the paper. But this, in my opinion, this is the only level 1 evidence. This is what really that's looked at this. And it's really easy to do. Just a bicarb tablet the night before morning of. Also make them NPO after midnight. And just keep in mind, mitomycin works on a concentration gradient. So, urine in the bladder is going to dilute it. So that's why you make them NPO. And in an alkaline environment, you get much better absorption of the drug. And we also do monthly maintenance. The data supporting that is not as robust in terms of high-level evidence, but I think it's good enough to suggest that monthly maintenance out to a year, so that would be induction, and then 10 monthly administrations once a month. And just remember that that schedule is not what we use for BCG. I'm going to get into that in just a minute. So these are the guideline recommendations for intermediate risk, and it does give us the option of chemotherapy or immunotherapy. And although, as I mentioned, my preference is to use mitomycin. This is some really elegant work that a group led by Don Lamb, Ashish Kamat, and others, which take that intermediate risk group and now risk stratify within it. So the occasional recurrent small volume, you can treat more like low-grade disease. And we'll often do office biopsies, fulgurations on these sort of occasionally recurrent small tumors, keeps the patients out of the operating room. And then they've identified an intermediate risk and a high-risk group within that broad category of intermediate risk disease. And there's a very nice publication that you can go into in more detail. So 63-year-old lady, gross hematuria, long smoking history, has a high-grade TA, so by definition high-risk disease, has muscle in the specimen not involved, no carcinoma in situ. Next step, BCG, every single time. I don't re-resect all TA high grades, though there's no harm in doing that. It kind of depends on if they're coming from elsewhere, if they're referred in, I'd always take them back to the operating room. If I did the resection, was confident in it, and the guidelines are, I don't always re-resect them, the guidelines are not, give us a little bit of flexibility in that. So in this case, the standard of care would be induction BCG with 3 years of maintenance. I'm going to show you the data around that. So SWOG 8507 was a randomization to everybody got induction BCG, and then half the patients in the treatment arm got 3 weeks of BCG at 3 months, 6 months, and every 6 months out to 3 years. Only 16% of the patients made it all the way out to 3 years. Some of those are recurrences, some of those are toxicities. That number was doubled in the EURTC trial, which I'll show you in a minute, but an undeniable, highly statistically significant reduction in both recurrence-free survival and worsening-free survival, which was a combination of true progression. Any patient who got systemic chemotherapy, radiation therapy, or had a cystectomy, and again, highly statistically significant. So this is the standard of care. And a couple of interesting caveats that 278 patients had CIS in that trial. So not surprisingly, in both arms, the complete response rate was the same after induction. But if you look here in the no maintenance arm, that without additional therapy, an additional 13% converted to CR at 6 months without additional therapy. So in some patients, the immune response takes a little while to develop. So the message there is that if you have recurrent or persistent, say CIS or TA disease at the first initial evaluation, don't give up on BCG. And then the profound doubling, more than doubling, benefit at 6 months with just the additional 3 weeks of maintenance, going from 55% to 84%. So when patients ask me, how's this all going to turn out? I say that you've got an 85% probability of being disease-free at 6 months with 6 plus 3. We all know that toxicity is a fact of life that we have to deal with when we're treating patients with BCG, and you can dose reduce and still maintain efficacy. Dose reduce to manage toxicity. Okay, as I'm going to show you in a minute, dose reduction is not really, we shouldn't be doing dose reduction or changing the frequency, particularly in the patients with high-risk disease. So this was a really important clinical trial. It was a 2-by-2 randomization of induction plus 1 year of maintenance, full dose on both, and then 1/3 dose, again 1 year and 3 years of maintenance. And the take-home message for high-risk disease was that induction plus 3 years of maintenance was better than induction plus 1 year of maintenance. So the standard of care for high risk, induction 3 years of maintenance, intermediate risk patients which were included, and you give BCG, you just need 1 year of maintenance. So I think that now you've got 2 large randomized clinical trials which show that induction plus 3 years of maintenance is a standard of care for high risk disease. And this is spoken to in both the, well this is another paper from the EORTC trial, just showing the forest plots from and the grade of evidence, and then here we go. So let me give you another case, 57. This is pay very close attention to this. This is a real patient, 57-year-old, very healthy guy, gross hematuria, high-grade T1, maybe getting to the gentleman's point during the Q&A, multifocal CIS. Obviously high-risk disease, and the doctor says, well, we can give you BCG, or we can take you back to the operating room and re-resect you. Okay? I told him, nothing's happening until you go back to the operating room to re-resect. They came to see me, and boom, got muscle-invasive bladder cancer, lymphovascular invasion, and we gave him neoadjuvant chemotherapy and a radical cystectomy, and he's done well since that time. So this study was not the cleanest study, but it's the only study that we really have. It was a randomized clinical trial with and without re-resection. You can see the Kaplan-Meier plot on the right, rather profound differences in survival with and without the second TUR, and obviously a big impact on progression. The presumption is that the second resection identifies those patients who are appropriate candidates for intravesical BCG, and those patients who we've understaged, which we know occurs quite frequently with high-grade T1 disease, that should go on to get a radical cystectomy. Let me be very clear, abundantly clear, that every single guideline is very consistent with this. So even if, you know, I did the resection, the initial resection, that patient goes back to the operating room. But a lot of times we don't know that we actually have a high-grade T1 disease, and so going back also gives us an opportunity to sample the rest of the bladder, because about 1/3 of those patients are going to have CIS, and we want to have a complete understanding of what's going on in the bladder prior to any treatment. So that is clearly the standard of care. If you take a previously treated patient population, so previous exposure to BCG, high-risk cases, that always sample the prostatic urethra, because that can be a reservoir for CIS, and that actually, at least in this study, I like this paper because it really highlights the need to take a look at the prostatic urethra in patients who recur after BCG. And this requires a TUR at 5 and 7 o'clock adjacent to the verumontanum particularly if you look at the sagittal section on the right and the highlight, the blow-up version, you see that that's where the prostatic ducts are. That's where you're going to find CIS. It always looks normal. You cannot assess this endoscopically. So in the patient who's recurred after BCG with a high-grade disease or an unexplained positive cytology, always sample the prostatic urethra, always. And then the sort of special case of high-grade T1 patients that recurred, progression rates are really quite high and require very special attention from us. So essentially a patient who recurs or has persistent high-grade T1 disease, we have to think very carefully about going along with radical cystectomy. So here's a lady, a healthy female, non-smoker, had a high-grade T1, really no high-risk features. I took her back to the operating room, and essentially she had large volume disease that I couldn't resect completely, recommended a cystectomy, and everybody's happy because the cure rate in this lady is probably about 95%. And so she was in that very high-risk category of large volume, high-grade T1. Some people call this an early cystectomy. I would call this an appropriate cystectomy. So understanding sort of when cystectomy is the right first line of therapy can be challenging, but it's really important for us to get this right. In the patients with high-grade T1, we'll say early or appropriate cystectomy versus delayed. You can see in the Kaplan-Meier plot a profound diminution in survival probability because those patients often have muscle-invasive cancer at the time of the cystectomy, and that's where you take the hit on survival probability. So it's indicated for the EAU very high-risk patients, and the AUA, some of the high-risk patients with large volume disease, high-grade T1 that's associated with carcinoma in situ. Unfortunately, really, there's no high-level evidence to support that. And then in the particular setting of recurrence after BCG, which I'm going to get into in some detail in the next talk, that would be the other indication. So it's critical for us to get an accurate assessment of stage and grade from the outset. Hopefully I've given you kind of a strategy for that. Risk stratify, and then it's really easy to figure out what to do. Re-resect every single patient with high-grade T1 disease, and then initial cystectomy is going to be appropriate course of therapy for selected patients with high-risk features, as I've outlined here. So happy to take any questions. Thank you. So two great questions. What's the definition of high volume? And well, certainly with high-grade disease, certainly anything that you can't completely resect. I gave you the case of the lady who had, I went in there and I said, look, I'm never going to get control of this endoscopically, much less to get you to a point where I can give you BCG. So some of that's going to vary between you, me, and everybody else in the audience. And it can also be a safety issue. I have a patient who's unfortunately passed away because I was never able to prove that she had muscle-invasive cancer, and she was very reluctant to undergo a cystectomy. And then by the time the medical oncologist said, oh, you need neoadjuvant chemotherapy. I said, no, you don't, because I don't have any evidence of muscle invasion. So I do a cystectomy. She's got T3 disease. She recurs, gets adjuvant chemotherapy. She's resistant, and now she's dead. So my regret there is not really putting my foot down strong enough and saying, lady, I'm not taking you back for another re-resection, in the hopes that you've got true T1 disease. So I think that to me, these are really hard decisions to make, especially when you've got a patient who's, pushing back a little bit on cystectomy. For low-grade disease, I'll take those patients back to the operating room as many as 3 times to try to get control. But if it's not happening, then I'll offer cystectomy. I try to avoid cystectomy in the large volume low-grade disease because the trade-off, statistically, the mortality rate with radical cystectomy at 90 days, it can be, in some series have reported as high as 9 to 12%. Fortunately, ours is not that high. So the trade-off is you've got a non-lethal disease, TA low-grade, and a potentially morbid operation. So those patients, I have no problem taking back 2 and 3 times to resect them.
In the case you presented, the TAG3 lady, you opted to go for BCG directly without doing a resection. So a re-resection, I mean. So the question goes back to, she might have, in the second resection, she might have a residual tumor. And, is there a problem of doing BCG when the patient has a residual tumor?
So a good point. The principle is, and this is probably where you're heading, is you want to completely remove all visible papillary disease prior to treatment. So then the other thing is that the timing of BCG, right? So you can start BCG within 7 to 10 days of your resection. Now, you know, life isn't perfect, and patients sometimes come from far away. And if you, what I recommend is if you get past, say, a 4-week window, let's say you're out 5 or 6 weeks, scope the patient in the office first, verify that there's no persistent or residual papillary disease. It's much easier for me to sit up here and say, look, if you have a TA high-grade tumor, re-resect everybody. Okay, but I just can tell you that the guidelines are not that dogmatic. But if you personally did the resection and you're confident that you've accurately staged everything, and you can treat them promptly, I don't think all those patients need to be re-resected. TA high grade, not T1.
I came across a patient recently where a patient who has like a really high volume disease. He had resections, like 3-4 resections before, and all the time T1 high grade. And he has bilateral hydronephrosis. Would you give this patient like a neoadjuvant chemotherapy before going to cystectomy?
Sorry, that's a good question. So a couple of things. Hydronephrosis, particularly if it's associated with, in the region of the tumor. So if you have an invasive cancer, T1's invasive, and hydronephrosis that you think is tumor associated, the probability that that's actually a T3 tumor probably is at least 50%. So that's number one. In the absence of, well, okay, let me step back. If your clinical staging, so clinical staging includes all the data that you get from the pathology. Remember, you got to do an examiner anesthesia with these patients where they're relaxed. Okay, and you're not feeling a three-dimensional mass, which would be T3, cross-sectional imaging. If you put all of that together and you say, that patient most likely has a muscle-invasive cancer, even though histology doesn't absolutely prove it, I'll treat him with neoadjuvant chemotherapy. We've done that quite a lot. And talking to my colleagues around the country, a lot of people manage those patients that way. But if you don't have hydronephrosis, if you don't have any high-risk features, and you've got a completely resected T1 tumor, well, let me back up. You've got a T1 tumor and you're going to do a cystectomy, those patients were not included in the clinical trials. Now, I know that my friends at MD Anderson will treat some of those patients with neoadjuvant chemotherapy. So, but that's going to be sort of not, well, I'll just leave it at that. So that's the benefit, I think, of using our multidisciplinary tumor boards when things don't quite fit into a nice, box.